Welcome to NU 623 Adult Healthcare, Unit 4, Presentation 1 on Lid and Conjunctival Pathology. Please remember to read all of the chapters that are associated with eye disorders in your text along with viewing this presentation.
Blepharitis can present as an ulcerative or non-ulcerative form, and a patient could also develop secondary infections. They may complain of bilateral or unilateral itching of their eyes, a burning or sensitivity to light, tearing, or feeling like there might be something in their eye. On exam, you'll see edema, erythema, and scaling. You may see ulcerations or pustules depending on the form at the lid margins, and thin or breaking lashes. It is basically a clinical diagnosis, but you do have to ensure there's no impairment in vision, so do a visual acuity test. And if there is drainage present, it can be cultured so that antibiotics can be targeted. The differential diagnosis is varied, and you can read those, they're listed here. Management includes eyelid washes, warm compresses, and topical or oral antibiotics or topical steroids. I want you to look in your book and you can see the treatment options for that. And then I want you to also see patient education in your book so that you understand exactly what you need to tell your patient to help clear this up. It is a challenging thing to treat because it has reoccurrences and it's very common. So please make sure you look at that in your chapter. For follow-up, you want to evaluate treatment in 2 weeks. And then if they're improved, you can recheck them in 1 month. But if you're not seeing any improvement or they're calling you saying, I have no improvement by 1 month, you need to refer them to a specialist, typically an ophthalmologist. Ophthalmology referrals should be done immediately for any red flag symptoms, including visual loss, eye pain, or corneal involvement. If you see inflammation or thickening of the lids, you want to refer, and if they have recurrent condition with treatment failure, you definitely want to refer them. Hordeolum and chalazion can often be confused. A hordeolum is an infectious stye and a chalazion is an inflammatory process. So the presentation is a little different. In hordeolum, you'll see itching, edema, erythema, scaling at the lid margins, tenderness, chronic redness, eye irritation, or drainage. And this could be internally or an external stye. A chalazion is very slow developing. It's painless. It's usually a hard lump, an inflamed red mass. You may see some nystagmus with this and some vision distortion. Again, you're looking at a clinical diagnosis, but if there's drainage, you want to culture it, and if the symptoms persist, you may want to do a biopsy. A differential diagnosis is obviously determining between the two, but then you have to think about squamous, basal, or sebaceous cell carcinoma. To manage it, it's going to be very similar to your blepharitis. You're going to do eyelid washes, your warm compresses, and then your topical or oral antibiotics. And please see box 19.2 in your book, and then patient education on page 267. For follow-up, that's just going to depend on the symptoms and the recurrence. Ophthalmology, again, should always be referred immediately for any visual loss, moderate to severe eye pain, recurrent episodes, treatment failure, or the need for a biopsy. Numerous etiologies exist for a dry eye, so make sure you read this in your text. The clinical presentation on eye disorders can be very similar, so a careful history and physical exam is needed to discriminate them. If you look at the symptoms and signs of a clinical presentation here, and then you look at the differential diagnosis, you'll see how it would be very easy to consider one over the other. This is why you're going to have to do a very good exam and use good diagnostic reasoning. As far as your tests, some of these tests can be done in the primary care setting, the visual acuity or the fluorescence staining. You could do a culture if there's drainage, and you can definitely draw some labs. The slit lamp exam and the Schirmer test, I believe, would only be done in an ophthalmology office. The Schirmer test quantifies lacrimal production. That's not one I'm as familiar with. You want to make sure you do rule out an autoimmune disorder in your patients, especially if they also are complaining of a dry mouth. You need to consider Sjogren's syndrome. When you have a dry eye associated with this particular syndrome, the term is called keratoconjunctivitis sicca. As far as management, make sure you eliminate your offending medications. You'll need to look up side effects for your medications on patients complaining of dry and see if you can change them. You want to use eye lubrication, and there's two types. There's drops and ointment. Typically, you're going to use drops during the day and use ointment at night because it can cause blurry vision. Definitely want to avoid any triggers such as wind. Know also that you might need to adjust medications because you can see there's several medications that can actually affect the dry eye syndrome, including hormone replacement therapy. Topical steroids, topical or systemic omega-3 fatty acids can be used, topical cyclosporine A. Punctal plugs can be done. This is an ophthalmology procedure, autologous serum, special contact lenses, oral inflammatory agents, and then there's surgical interventions that also can be done if it becomes persistent or severe. Patient education is listed in your book on page 269. Make sure you look at that. And then as far as follow-up and referral, you're going to reevaluate depending on your symptoms and the progression of the disorder. Ophthalmology would be needed promptly for an accurate diagnosis and any specialized treatment, or if you have treatment failure. Excessive tearing, or epiphora, can be the result of trauma, infections, or dry eye. Clear tears will be running down the cheek or collecting in the lower eyelid pouch without any provocation. The patient may also have allergy symptoms, asthma, or other atopic diseases such as eczema. For diagnostic testing, you're going to want to always check visual acuity. You can do fluorescence staining with a Woods lamp. A slit lamp exam is typically done in the ophthalmology office. Understand that if the patient has blurred vision, diplopia, photophobia, or eye pain, this could indicate a more serious condition, and you're going to want to send them on for immediate evaluation. Differential diagnoses can be varied. Could be a foreign body, could be a corneal abrasion, conjunctivitis. There could be a blocked duct. Notice that there are certain disorders that will affect the eyes unilaterally versus bilaterally, and this can assist in your diagnostic reasoning process. When you're managing these patients, if they're a contact lens wearer, they need to be wearing their glasses until the infection resolves. If there is an infection, they need to use topical antibiotics. If you do have to remove a foreign body, make sure that you evert the eyelid to check for foreign bodies that are not immediately visible. If they're present and they're not embedded, you can use a wet cotton swab to swipe the eye surface. If they're embedded, you need to patch the eye and send them immediately to ophthalmology, but also consider tetanus prophylaxis based on what the object might be. They're going to need eye rest, cold compresses. They may need topical antihistamines, NSAIDs, mast cell stabilizers, or oral antihistamines. And you can see a chart on page 272 of your book. It's table 19.1 for that. Follow-up and referral. If it does turn out to be a corneal abrasion, you want to follow that up in 24 hours because corneal abrasions can progress to corneal erosions, which are more serious, and if they're not treated properly can result in some permanent vision loss. If it's something like allergies or conjunctivitis, you can certainly follow them up in 2 weeks. For foreign body removal, you can send a patient either to the emergency room or immediately to ophthalmology. Ophthalmology would also see patients with chronic symptoms or if they need specialized tests or treatments, and to follow corneal abrasions and erosions actually. Allergy testing can be done as well by the allergist. Red eye or conjunctivitis is a diagnosis that you're likely to see a fair amount of. What you need to know is that a red eye is always a red flag, so it has to be assessed thoroughly. The clinical presentation will involve hallmark symptoms, which is the itching, watering, redness, and the sensation of something in the eye. You can see inflammation, eyelid edema, the presence of follicles, which are dome-shaped mounds with blood vessels, and subconjunctival hemorrhages. The patient may complain of light sensitivity or eye pain or have decreased visual acuity. In a bacterial conjunctivitis, you're usually going to see it starting unilaterally with thick, purulent discharge, and they're going to say that their eyes are matted shut when they wake up. In allergic conjunctivitis, it's typically going to be bilateral with a lot of itching. There'll be some moderate tearing, but you're not going to see any exudate. Viral conjunctivitis should be bilateral as well, and it's going to have profuse tearing, not as much itching or discharge. And you might see some systemic viral symptoms, especially like a preauricular adenopathy. Please see Table 18.2 in your book for additional information. For diagnostic testing, visual acuity always has to be done anytime there's an eye complaint. You want to check pupillary reaction to light and accommodation as well. You can use a Woods lamp with fluorescent staining if you think that there might be an abrasion or a foreign body. You can do a culture to rule out any kind of a herpes or a chlamydial infection if it's indicated by your history. Make sure you read this section on differential diagnosis in your text, page 274 to 275, because you are not going to want to miss one of these other disorders that could have devastating effects on vision if not treated. Your management is going to depend on the etiology and your visual acuity that you come up with in the clinic. I want you to see the drugs commonly prescribed, page 272 in chart 19.1. You want to make sure that you keep the eyes clean, use artificial tears for comfort, avoid contact lenses. If it's a bacterial infection, topical antibiotics, moist compresses, topical antihistamines, NSAIDs, mast cell stabilizers, and oral antihistamines can all be used depending on the etiology as well. For follow-up and referral, you want to follow up in 24 hours if the condition worsens, because it may be a developing situation on one of these differential diagnoses, or you want to otherwise follow them up in 2 weeks to make sure that the condition has cleared. For ophthalmology, you're going to refer if there's unresolved conjunctivitis or suspected herpes, ulcers, keratitis, or corneal erosions. If you have an abnormal pupil reaction to light, if you have a persistent case or need specialized tests, also the presence of a hypopyon, which is a layer of white blood cells, or a hyphema, which is a layer of red blood cells in the anterior chamber, those are going to require immediate referral to ophthalmology. You may also want to consider sending them to an allergist for allergy testing. Again, please read the corresponding chapters in your textbook and check your course module for any links for resources.